Um, Mr. Pranav, I think we are live.
We are live.
So maybe
So,
you want to give some housekeeping uh, kind of instructions, then I will take over.
good afternoon, everybody. So, very happy to see more than 54 people already join, and I can see the track here. A couple of more are on the words. Yeah, they are joining too. So, good afternoon again. We are entering into the fourth session now. What we are feeling a little bit difficulty in internet connection today. So just wanted to communicate you in advance that sometimes when the internet connection in any of the point, if it is goes down, then our video will go out, but you will still be able to see the slide and audio. The slide and audio will be always there. It will never get connected. In case you see any lag, any problem in at your end, I request you to just see at the top of your system, mobile or internet laptop, you can see a red button called reconnect. Just click that reconnect button. You will be again get reconnected, and the visuals will be perfectly thereafter. So use the reconnect button whenever is required. With this, I invite Dr. Rangareddy Garu to start the conversation, who is going to chair today's session and introduce the speaker.
Very good evening, colleagues. I'm very happy to see again a lot of interest in otherwise boring topic called as epidemiology. The last three sessions, we had a wonderful participation of more than 200, 300 people. It is really heartwarming that, so many people taking interest in the basics, which is ultimately going to help all of us who are in the public health, who are in, infection prevention and control. Otherwise, also every healthcare personnel who is concerned with outbreaks, epidemics, and pandemics. And a very warm welcome once again for the fourth edition of this series, which is named as Outbreaks, Epidemics, and Pandemics, a holistic approach. Last three sessions, the first two sessions were dedicated more revisiting actually the basics, and then also understanding the importance of the natural history in epidemiology, and applying some of those definitions, tools, etc., to the current day reality. And the third session, which was taken by Professor Moti from Indian Institute of Public Health, he has actually helped us to allay the myths, misconceptions, and misrepresentations related to epidemics and pandemics. And he has actually given us a lot of insights into how the decision-making process happens during outbreaks, epidemics, and pandemics. And also, he has given very beautifully the application of actually the management principles like 80-20 for our healthcare system. And he has also given the manifesto of ICE, which has given us some kind of tool or a set of tools in order to deal effectively with pandemics, especially the COVID-19. And today, is going to be an equally interesting session. Uh, Mr. Pranav, I am unable to actually, yeah. And before actually we move into the topic of the day, I would like to congratulate all the nurses across the world, across the globe, who had been actually in the forefront of fighting COVID-19. Even otherwise, also in our clinical setups, they play a very vital role, not only providing the necessary support for the patients, but also to ensure that the kind of care we give is the safe care, and to ensure the patient safety. And today, on behalf of all our organizations, I would like to congratulate all the nurses everywhere, especially those who are in the class today. Now, I would not actually burden you talking again about the objectives of this series. For last three series, most of you have participated and you are already well aware of. Basically, the series, in one word, it was started with a view that how do we understand the epidemiology and how do we apply the principles of epidemiology for our current situation of COVID-19, and also going ahead dealing effectively with outbreaks, epidemics, and pandemics in communities or globally, right? So this series, as you are all aware of, had been made possible with the academic grant from Sunmed Healthcare, and this is jointly organized by Infection Control Academy of India, University of Hyderabad, and Indian Institute of Public Health Hyderabad, which is part of Public Health Foundation of India. Now, today we would be taking the fourth session, but before going again to the fourth session, I would request all of you who have not actually taken the assessment, please do complete. And you can see actually on your screen the URL for taking the assessment. And as actually has been mentioned in the beginning itself, that at least you have to take 4 out of 5 sessions and the assessments in order to earn a certificate, which is going to be very valuable certificate. And some of you have written in private to us and also to our secretariat requesting for the certificate for individual sessions. Please let me clarify that there are no individual session certificates. There is going to be only one certificate, which is going to be a certificate of completion, who take the participation of in at least 4 out of 5 sessions. And now coming to the session of the day, right? Um, today's topic is the importance of data and its uses in epidemiological modeling during the pandemics like ours today, and lessons from current experience. As we all know that we are going through a once in a lifetime kind of situation today with COVID-19. And there is no guarantee that these kind of instances or the pandemics are not going to be repeated in our lifetime again. And hence, we as healthcare professionals had to learn from our current experience and make good out of this in order to implement better practices in our institutions, better practices in healthcare setups, and also overall at the community level too. And I have privilege today to introduce my friend, Professor Giridhar Babu. A warm welcome to you, Professor Giridhar. It is really an honor and pleasure to introduce you. Uh, Dr. Babu is a professor and head life course epidemiology at Indian Institute of Public Health, Bangalore. As mentioned earlier, IPH Bangalore is also part of Public Health Foundation of India. He has done his MBBS from Kasturba Medical College, Manipal, MPH and PhD from UCLA, United States. He has worked for more than 2 decades in public health research, practices, and academics. He worked with the World Health Organization for over 6 years and leading Karnataka team efforts in stopping polio transmission in state of Karnataka. He initiated the advocacy of measles surveillance in Karnataka, and he had been awarded with numerous prestigious awards, and one of them is Intermediate Fellowship of Wellcome Trust, DBT India Alliance. And he has more than 80 publications, both in national and international high impact journals. And very specifically, talking about today's scenario, probably he is one of those top experts who had been dealing with the COVID-19, uh, sitting in the war room, preparing all those models in order to uh, help the government to decide on what we keep hearing, the lockdown 1, lockdown 2, lockdown 3. Probably he would also give an insight whether there would be a lockdown 4 and 5, and how long it is going to take place. I am sure, we are all going to enjoy this session. Definitely, it is going to be a lot of numbers. Just before the session, I was joking with Professor Giri that I always had been scared about the numbers and the symbols. I think, today's session, he is going to remove that fear in all of us to look at the numbers and also symbols and make some sense of all these modeling in order to apply them in our day-to-day life in dealing effectively with outbreaks, epidemics, and pandemics. With these few words, once again, a very warm welcome, Dr. Giri. Over to you, sir.
Thank you, sir. It's my privilege to be part of this series, which has been led by the director, IPH Hyderabad, and other colleagues. Thank you, Rangareddy, sir, for a very generous introduction. So I'll go on to the slides directly, and I'll start with this most important pictorial representation of what's happening, not just with the COVID-19, but with everything else we see in science. So for each one of us, we think based on the circumstances around us, the knowledge that we have, and also what we are observing. So if you see this diagram, each one of the person is right in saying what they're saying. So for a person who is holding onto the tail and saying it's a rope, it's the reality for the person who is holding onto it. So on a macro level, each discipline is looking at an epidemic or a pandemic like this. Economists see in a different way, epidemiologists see in a different way, social scientists see it in a different way. Yet each one of them is right. But then how do you make sense of the entire picture is the most important thing. When it comes to modeling, the same principles apply here. What do you know about the entire picture in certainty? Can anybody be certain? Or are you holding on to a trunk or a tail and then saying, this is the elephant? So that's the most important thing before we go on to the use of data. Some terms which we should be aware. Most people confuse these terms for one another. But when you want to do a study, if you reduce the random error, just by increasing the sample size, it's called a precise result. But to say there is validity, there should be no bias or no source of systematic error. I'll just explain what that means, bias is. What is bias? It's so difficult to be unbiased all the time because we have so many things confounding us, so many errors that what we observe. But what is bias? Bias is something that takes away our attention from the truth. Now, what's the truth? Truth is, again, elephant. But do you get the elephant, or do you just get the trunk or the tusk or the tail? So anything that takes away from the focus is called bias. I wouldn't go into the lot more technical details of what the definition of bias is, but then let's just focus that what we need to get to is the truth and nothing but the truth. What takes you away from the truth is one set of errors that we call as confounding, where you get confused between the effects of the other variables and the variable that you are interested to see. So for example, now we are seeing that infection is spreading, but then we say testing rates are a confounder. What does that mean? That means that testing rates will determine how many people are getting infected. So that's one way of looking what a confounder is. The next thing is selection bias. Whom do we test? Generally, we tend to test those who are either had a history of travel or those who come to the hospital. So are you testing really whether people in the community are there or not? So this we call as selection bias, where only you're selecting a group of people for understanding what the truth is, whereas you're not doing it for others. That's one error. And the most important error, which is present almost every day in everything that we do, is called measurement error. We have errors in measuring everything, including our ignorance about what's happening. So these are the three main sources of systematic error. And we have to be aware of this whenever we are analyzing anything about science. Once we know what bias is, and then we want to get to the it's very important to spend some time in understanding what are the disease dynamics here. So if you see here, the two small teapots are the ones through which the disease incidence is occurring, and then it comes into the community. So if you see that big spot out there in terms of a big pool, that's the pool in which the disease gets accumulated. So the only way you get out of this is either there is cure or there is death. So there is input in terms of incidences, there is output in terms of cures or deaths, and then you have this which will tell you how much infection is there. This is an important thing to understand in terms of a disease dynamics, who gets in, who gets out. And for COVID, all the incident cases are either has to be through either related to travel or contact with somebody who is already infected. So these are the ways in which it can come. Can it also come by other means? Yes, but let's find out those. These are the major ways of getting the disease. So if you are not in touch with some this, so if you want to see that entire big pool out there, if you want to reduce the level of infected in that, there are two ways of doing it. One, control your what is coming input, so which is incident disease. How do you control that? You will control that by making sure that people don't come in contact with those who are infected. Very simple. How do you do that? Lockdown is one measure, but this is an extreme measure of preventing people from getting infected. Otherwise, physical distancing, using masks, and making sure that you're practicing and washing and cough etiquette. All these will prevent this input. The next thing is in terms of how do you control output? I mean, obviously, nobody would want to have more deaths. That's a very wrong way of reducing the prevalent pool. But cure, yes. But do we have a cure for COVID? No. It is self-limiting in the sense that nearly 90% of them who get infected, 90 or around that, will get a resolution, whereas remaining 10 people might require some support. Even within those 10 people, few might succumb to the disease itself. So when you want to make sure that any model is run on understanding how much the disease is, you need to be aware of all of this. What is the inflow of the infection and what's the outflow of the infection in the communities? So now my topic is in terms of whether the data that we have, what are the problems with that, and what do we do about getting a good data? What are the current practices? How do we improve? So data. So now what data do we need? We need data on the inputs. We need data on what kind of people are infected and what is the total pool of in this big tank that you see there. You also need what proportion of them get cured, what proportion of them die. So in this one picture, you would know that what are the different data elements that one need to calculate, both at the individual level and at the population level. And that's where the challenges start. So for example, I'll start explaining the models, then I can explain you the problems where data collection is, and also the quality is a problem. So we all know, and it's not a surprise for us, that in India, whatever the data that we have, it's not so robust, and there is also under-reporting of the data, which comes from a basic fear and stigma that if somebody is infected, people might put them in the isolation, or if for those contacts, they might be put in the quarantine. So how many people actually report that they have infections? So I can give you two hypothetical examples. Let's say there are two states, state A and state B, and let's say both of them have the same per capita expats. Out of 100, let's say 10 people are expats, and both the states will receive these 10 people from outside just before the lockdown. Ideally, the 10 people who are infected, among the 10, let's say 5 are infected. When they come to the airport, few are symptomatic, few are not symptomatic. So once they get detected in the airport, then we need to trace their contacts. So if you are able to do such systematic way of finding who came in, maybe we could have prevented, because we had enough time from all over the world to know that which places were hotspots and where are the people moving in. So one of the ways in which you can control, which is what New Zealand is doing, is that make sure whoever comes from these hotspots are clearly, examined, and then follow both them and also their contacts. Clearly, that did not happen, at least in this country. So different states are in different stages of transition of the epidemic. Part of it is due to under-reporting. There's also fear of reporting deaths due to COVID. So let's agree on that there is incomplete data, whether it is out of voluntary acts of not reporting, or whether it is because of ignorance, or whether because of the lack of systems. There is under-reporting. Next, the data what we have is not completely reliable for two reasons. One, the way we collect the data. Two, because of the disease itself. So regarding the way we collect the data, I am sure most of us know what the problems are. But then by the disease itself, what do I mean by that? Nearly 80% of the people with the infection are so-called as asymptomatic. But what does that term asymptomatic mean? If you want to break it up further, it comprises of three subgroups. One subgroup, which is a very minor fraction, is asymptomatics who are truly asymptomatic and they don't want to develop any symptoms later on. The other group is pre-symptomatic, in the sense that we have tested them earlier, probably, but they'll get the symptoms a little later. So they are pre-symptomatic. And there's another group who have atypical symptoms. So for example, CDC recently expanded the symptoms criteria, which included loss of smell, loss of taste, chills. So they have included 5 more symptoms. But currently in India, they would be falling within atypical symptoms. So even if they have, we don't necessarily take the people to be infected. So when you have such complex presentation, which is a majority of the people, which is 80%, how do you then take that into account for any of the modeling? Especially, let's assume there are 100 people out there who are infected and 80 of them are asymptomatic, which comprises of these three groups. How do we know if we don't test whether they're spreading the infection to others or not? You have to assume, right? I mean, let's assume what proportion of these asymptomatics is pre-symptomatic, what proportion is truly asymptomatic, what proportion is those who are having atypical symptoms. But in net, you are assuming, and these assumptions are the ones which will tell you how robust or how strong or how practical is your modeling is. So that's about the data availability. So one of the things that, this is written as poll 1, but I had listed out things where what we know and what we don't know about this coronavirus. So one of the things is, can coronavirus reactivate in recovered patients? Yes or no? So I mean, how do you know? You'll have to do the research. So many things about the novel coronavirus epidemic is novel by itself. So we are not really sure. Next is, can people become reinfected after getting infected? Can coronavirus reactivate in the recovered patients? We don't know as of now. Can they become reinfected? We don't know. But what do we know? We know that there is false negatives on the test, which means around 15 to 30% of infected people will test as negative, even if they have the infection. And you can tell them it is negative, they keep on continuing to spread. So that's a problem that we know that it exists. And this happens with the most commonly and widely recommended test. The next thing is the case count might itself be wrong. So this we already know. So the simplest explanation and the simplest way of taking forward what modeling can be done is by following this occurrence razor, which says that let's try to explain in the most simple way of what a model is, and through that let's understand what's its implications on epidemiology of this COVID. What's a mathematical model? It's description of a system using mathematical concepts and language to facilitate proper explanation of a system. This is what Ranga Reddy sir said, that people get scared the moment you start using math. But this is the definition, and let me not read the definition of a model as. And a model is, let's say, an equation which tells you about something in a systematic way. So that's the minimum way of understanding. So we use models for several things, and in epidemiology we use it more for how the disease is spread, to understand that. You can also understand several things through modeling, and when you run epidemiological studies, you use one or the other form of models to explain your findings, to understand how the disease pattern is. And currently what we are limiting our discussion is on how does it spread and what are its implications for a country like India. Again, it's not something new. It has been in practice for a long time. Daniel Bernal was the first person who tried to map the spread of smallpox, and then John Snow used statistics and mapping to show how cholera spreads. Right now, what we are doing is we are using advanced mathematical processors and even understanding to explain how diseases are spread. So one of the models that we generally see more often is called a compartment model. The word compartment says that these are the fixed spaces in which we assume that people are there. So I'll explain the next slide on what these compartments are. But what we assume is that once you make these compartments, everybody within these compartments are almost same, what we call as homogeneity. So that's one of the assumptions that you make when you do these compartment models. So the most famous model out there is SIR model, susceptible, infected, and recovered model. So you have these three compartments where in the first group, so if you go back to the slide and then see in terms of how I explained these, in terms of how the disease input and disease gets reduced, I showed you a big prevalent pool, and then through that I showed in terms of what is the way in which the disease comes in and how the disease goes out. There I had said the only way you get into the infected person, infected pool, is by coming in touch, being in contact with person who is already infected. So the first group here, the first compartment, is susceptible. What does it mean? That they do not have the infection yet, but they're at the risk of getting the infection. So a concept which is most popularly known within epidemiology as persons at risk. That means that they're at risk of getting infected. So this is the pool. So currently, my guess is at least 60 to 70 or even 80% of the entire country is susceptible, which means if there were to be a corona virus, some novel coronavirus somewhere around, and it stays long enough in contact with this 80%, they should move on to the next one, which is infected pool, infected compartment. Now, that's a large majority of people who are susceptible. Now, do we know what proportion of Indians are susceptible? You can take a best guess in terms of, look, let's assume that people have come into this country and we have contained them in particular geographies and in time. So therefore, we have not allowed it to spread to others. Therefore, a majority of the population in India is susceptible. So again, this is the assumption that we are making. The next compartment is the compartment of people who are infected. So in this, once you're infected, you move from susceptible pool to the infected compartment, and then the rate at which you get into this at a point of time, that's what you calculate, and you use in the equations. But I'm here only to tell you the data on how we assume all of this. So who are the people who are infected? How do you define it? These are the people who are tested positive after having an infection. But do all people test positive after getting infected? No. The viral load is typically high only after 5 or 7 days. Therefore, you'll start getting tested positive only after 5 or 7 days. So if you test in the first 5 days after the infection has started, you may not test positive. Plus, we are saying around 70% of the people, we can say with certainty, but 30% is false negative. So that means even the test is not all right. So therefore, you would never know what the actual proportion of infected people are, or what is the total N or sample, or the real population size of the people who are infected in the community. But you can always make a best guess depending on what data you have, and then you have that compartment. Then you have this recovered. Who is completely recovered? Again, how do you define what recovery means? If we say, look, if the symptoms disappear, so from symptomatic, they become asymptomatic, and that's when I call as them recovered, probably that's not correct. Because after the symptoms disappear, some of the studies that are shown in these countries have said they continue to shed the virus for nearly 2 weeks. In that case, are they as infectious as those who have symptoms? We don't know. Is it because of these people spreading to others that the reinfections occur? We don't know yet. So again, what does recovery mean? Recovery from symptoms, recovery from virus shedding, or becoming immune? So again, your model depends on what these assumptions are, what is our definition, what is the actual data on each of these are. And let me again remind the audience that this is the most simplest model out there. And even with the simplest model, I've just explained how it is difficult to assume the actual number of people who are susceptible, the actual number of who are infected, and those who are recovered. There are two properties in it. One is the way we get the information. The second is the virus and its how it is affecting population. So when both are uncertain, can any modeler give you a certain prediction in terms of how many cases we'll have, how many we'll have by what time, how will it be for, I mean, see, in this model, we are not even considering whether one group is heterogeneous or not, whether states are different or not, whether health system is robust or not. This is purely thinking that everybody within this compartment is same. Even with this simplest model with the most strong assumptions, I've just explained how difficult it is to get predictions all right. So So that's why I say there's a lot of difference between astrology and modeling. Astrologers can be very certain in terms of telling what's going to happen. A modeler, if he uses certainty to say that, oh, by this date you will have these million cases and these many deaths, and my model is the perfect, then you should actually doubt because of the assumptions that I've just explained. You cannot have certainty, even if you have a confidence interval. If you don't understand what's going on with the virus, with the disease, and with the population and the compartment distribution, you will rarely get that kind of certain predictions. So if somebody gives us certain predictions, you can go on to the next predictions, which is uncertain. Believe uncertainty, not certainty. So the next one is, I'm just going to explain the assumptions in this simplest model. So one of the assumptions the SIR model makes is no one joins the susceptible group. So it's all fixed in number, nobody comes in. But we have just allowed the flights to come in from affected areas. Even if states are susceptible so far, the trains that are allowed are going to bring the people into it. So again, this assumption is difficult, but you'll have to assume somehow and then go on with the modeling. You can't have a perfect real world out there which does not have any of the problems. So that doesn't exist. So therefore, you'll have to make assumptions anyway. The next two assumptions are all individuals in the populations have the same probability to contract the disease, and their age distribution is uniformly distributed between 0 and life expectancy L. I don't know whether any country in this world will have this kind of thing. Can each one of us have the same probability of contracting the disease? Even if there is one infected person in a room with 10 people, will all of them get the disease? Will all of them have equal probability? Probably not. So that's the next assumption. The third, I already explained earlier, there is homogeneous mixing of the population. So anybody knows India, and if they say there is homogeneous mixing of the population, then probably both things don't go together, which means that you can certainly predict the way people spread the infection from one to another. And when you have small groups, there are some small groups everywhere, even within a workplace. And now we think of a country and then say, look, we are assuming uniform distribution, and we can. So that's a strong assumption. So that's where this article says, if measuring the present is hard, predicting the future is even harder. If I really don't know what's the total number of people who are susceptible, who are infected, and whatever we are getting now is just the tip of the iceberg in terms of those who are symptomatic and tested positive, and then whom we have recorded. So if measuring all these compartments is so hard now, as of today, how can we be certain about predicting the future in terms of what numbers we might have? So one of the most important things the SIR models have is called R0, which is called as basic reproductive rate. What it says is it's on an average, one person who is infected, how many more people can that person infect? That's what R0 or R0 measures. So for a disease like measles, it's around 18. That means one person who's infected can spread to 18 more people. For influenza, it will be between 1.5 to 2.5. For COVID-19, it is around 2.3. That means one infected person can spread to at least 2 more persons. So what are the advantages of this, the simplest model? So every other model can be a lot more complex than this, but then this is probably the most realistic and most intuitive way of understanding, and therefore it can be explained better in terms of what modeling is. But now to the same model, SIR, I can also add another group which is called exposed between S and I. And don't know to get into the details of it, but then even within E, I can actually make subgroups, like how I explained within asymptomatic. There are 3 subgroups, and that I can build into the modeling. So all these modelings use equations. I'm not going into the details of the model per se. My assignment here was how the kind of data that gets into the modeling, what kind of data that comes in, what are the problems with that, how do we move on in terms of having a realistic model. So I recommend there are absolutely brilliant modelers in India. There are free videos now available. There was just one webinar on by the India Science COVID group, which had beautiful videos which are put on YouTube. I'm sure it's available now on public domain. So go into the details of each mathematical modeling. I would recommend those. But here, let's limit ourselves in terms of what the data that comes in and what these models generally mean and how we can improvise on that. So the proportion of susceptible people decreases. So you know that there are 3 compartments. So the moment somebody gets infected, they go on to the next compartment, which is infection. So now, can I assume that this rate at which goes from susceptible to infected compartment is at a constant rate? Can that happen? Probably yes, maybe during lockdown. But after that, so these are the constants that we use in assuming these.
Professor, there is a voice problem. I think we are not able to hear you at this moment. Professor, we are not able to hear you at this moment.
I think he's going to rejoin. Looks like the video is gone, so must be rejoining. In the meantime, those of you who are already in the classroom, probably you can start sending your questions so that those can be compiled and so that we can make use of Dr. Giri's experience in order to get the clarifications from him.
Professor got disconnected. He's trying to reconnect again.
Yeah, kindly stay in the room because what is going to come up is in further slides a very interesting way of explaining in a very simplistic way the equations, models, etc., which can be very effectively used in our day-to-day life in our healthcare institutions.
So, by the time Professor is joining, let me put a poll here. All of you must have some idea about this model. So, see, wanted to know your opinion. There are a couple of model like ICMR model, University of Michigan model, John Hopkins University model, Cambridge University model. Which model, as per your current information which you have, is the best one. So you can respond the poll. You can see at the bottom. Yeah, I see response is coming up. I think Professor also rejoined. Professor, we are just running a poll at this moment when you are away for few seconds. We are asking that which model, as per their current information, which is the best model. I'm going to, I know that you are going to explain each model now, but before that, let's have the opinion of the our professionals, what they see. And most of the people are favoring India, ICMR model. Good. So I'm just ending the poll. I'm publishing the poll here. So you will be able to see, all of you will be able to see now the opinion of the 111 professionals. 54% favors ICMR model, while 15% John Hopkins, and 26% says that all the models. So over to Professor Giridhar. Please take it forward. Which model is how?
Sure. Yeah, sure. So thank you. I'm sorry for the disconnection in between. So the assumption when you I have explained the assumptions. Now the way we calculate is if you put S plus E plus I plus R. I is, as I explained earlier, SIR. E is the exposed. The total thing should come to 1. So you make your best bets in terms of each of these compartments in terms of what the total N is, and then totally it add up to 1, right? And this is the most commonly used model. And even the first predictions in terms of what happened in China was reported based on SIER model. So I have explained the limitations of SIR in terms of what the assumptions are and how the data flows in about each of those compartments. And about E, I've also explained in terms of asymptomatic, what happens when the asymptomatic itself is of 3 different subgroups and you don't know. So when I say you don't know, this is both a property of the disease and the population. But if you start testing people for IgM and IgG, you would know that what proportion of them are infected. And then you would also know whether they had symptoms or not. So you'll have to do a lot more research to find out what fractions or what numbers are actually each of these compartments are. So in terms of these employing these models, the first model was, I am limiting my discussion to 4 models here. And there are many models where people have not explained what is the methodology that they've used. So when you want to understand a model, the most important thing is also to understand, what is the basics of this architecture, what are its assumptions, and then is the data or is their modeling results are available for scrutiny. So all these things are very important. So based on those considerations, we can discuss on those 4 different models that in India we have been discussing so far. The first one is by Indian Council of Medical Research. The second model is by the group at the University of Michigan, and the third by the John Hopkins, and fourth is the Cambridge University. So what did ICMR study do? They followed SIR. They also added exposed between S and I. And based on this, they said several scenarios are based on the different reproductive ratios. But what the main goal was, they wanted to look at interventions which will reduce the overall burden. So this model suggested that between 1 and 10% of the population will be infected. Again, this is based on an assumption that let's assume 1% get infected versus 10% getting infected. And based on that, what are the different possibilities? That's what ICMR study did. The Michigan study also looked at, this is closest to the classic SIR, and it is different from the SEIR, which I described for the ICMR study. And it uses the number of cases observed to restrict the model. And it predicts the future events, including intervention, quarantine, and lockdown effects. So if you go to the results of this, it will tell you in terms of lockdown is there, how many cases you'll have, if it's continued, what will happen. According to this, if nothing is done, if there's no intervention is done in the country, then there will be around 16 cases for 10,000 people. Now, you can calculate in terms of 16 for 10,000, what will be for 1.3 billion. Obviously, a lot more than what we currently have. According to me, even the districts which have highest infections right now will have between 30 to 50 per million population. But here it is 16 per 10,000. So obviously, we have to respect their assumption. It says in the absence of any interventions, but it's not the case. We have had interventions in the country. So the John Hopkins group, they apply both standard epidemiological modeling and they include agent-based modeling. And they provide state-level information for the number of infected people as a function of time. So they definitely, it's a lot more detailed, and they also look at what happens in the metros, and they give a lot of priority in terms of how the demographic variables vary at the urban versus rural. The final model is an SIR model again by Cambridge. They look, and this is probably famous for many other reasons. I have not included other models. I'll just describe in just a minute. This describes the effects of a lockdown by changing parameters to represent total switching of infections. So they say 21-day lockdown will give you this number, 48-day lockdown will give you this number, and which one will reduce or flatten for a longer time. However, it ignores the asymptomatic infections. So these are the four models that have been discussed. And before, I know Mr. Pranav was trying to run a poll, but polling is one thing, but then let's, I want to express few of my concerns about the overall perception about modeling and modelers. There is a perception that people who do modeling want to somehow give numbers which scares people. So let's respect, nobody wants to see people getting affected. And whatever they're doing their best in terms of predicting based on a certain assumption. You can test their assumption, you can question their assumption, but don't question the modeler. I mean, they are as like you and me, and they're trying to contribute to overall planning and preparedness, like how we would want to do. So the modelers are here to help. But the famous saying in epidemiology is, all models are wrong, only some are useful. So what is useful for us is for us to decide. Instead of shooting the messenger, or instead of saying the modeler is wrong and that and this, let's say that, okay, each model is wrong. I'll only pick up what is useful for us. I think that's the way forward. So therefore, I don't believe, I know that this is required for the course requirement, but then I do not believe that we should be doing a poll or an opinion of which model is better than the others. I believe each model will have its own set of flaws. So going on to the next, then what do? If there is a problem with the modeling that we do, what do we do next? What should I believe? So let's look at what we believe in, how the country is changing in terms of what modeling we are doing. So this is where I bring in a model that is contextual, a model that considers India as not as one unit, but as India as a country with many states in it, and each state is different. And within each state, each district is different. So a good model or a best model should be able to tell me this information at the level of state, not at the level of the country. So that's one good thing. And are there models out there? So I'm yet to see the details, but based on whatever I saw in the webinar, the India Science COVID group, this ICMR model by Professor Gautam Menon and others at the Ashoka, and there are many collaborators. This takes care by addressing some of the limitations that I explained earlier in terms of even within infected, looking at different combinations. So this is how they've described their model, and they go on to have these equations where they say how within exposed group how different proportions exist and how it will have implications on the overall burden. The other set of models is what I participated in, and you will always say whichever you get involved in probably is the best model. So I don't want to be biased there. But this is done by IIT Bombay, and then there are several models by IIT Bombay. It is freely available on the public domain. You just click on IIT Bombay modelings, and then you can go on to at least 6 models, and it will give you, it's almost real time because they are trying to update this based on everyday information. So what we used in this modeling is, we used a CIR type of model, but we looked at several uncertainties, and instead of making homogeneous assumptions, we did a lot of explanation in terms of how the states can differ, and how can you account for the kind of differences that the states have in terms of their health system, health-seeking behavior, socioeconomic status, vulnerability index, so several things like that. So, and we went a step further, and then we have done district level modeling. When I say we are just the epidemiologists who have consulted on this. It is the modelers who have done most of the work. So these models, in terms of understanding what the and then ICM principles are also used, where you know already some information and there is this current data. How can you make both of these available information to make predictions? And they consider this to be the most a better way than the frequentist way of assuming. Finally, we have included open source code for peer review and extension. Anybody can come and review our work, and they can extend this. So that's the model. But any of these models, we need to then include it only whether what kind of use this model has, whether this model or the model by Gautam Menon and other group, and there were various other modelers who have done. What do we want to do with these models? Can I use this model to predict when the lockdown should end? Can I know in terms of what proportion of people who are tested, and then what should the next strategy be? What is the relative importance of distance, physical distancing measures versus lockdown? How can I predict future hotspots based on this modeling? And these are the ways in which you can use the modeling. So that's what we should be using these models for. Yes, there are models, but how can I tailor one particular model to give me an answer for these questions? I think this is a way of looking at what kind of use the models will have. So in the models that the IIT Bombay group did, they looked at if you extend the lockdown till May 3rd, what happens? And if you extend till 15th May, what happens? But now we have passed all these deadlines, and today night we will know whether it is going to extend or not. But then you will use these kind of interventions and see what is going to be the overall impact of those interventions. And I think that's the way the models should be used. So far, what we found was that increased identification through syndromic approach and testing and quarantine will offer to reduce the overall spread. And states which have done good testing and who have relatively better health infrastructure are the ones who are controlling the epidemic quite effectively. And then you have some good measures in place, such as physical distancing and the contacts at various places. It will have a really long-term effectiveness in terms of mitigating the spread. And after the lockdown is over, how do you prevent migration from areas with high burden to the areas with low burden? So how can I use these modeling results? So these are the things that we have been able to conclude based on that. But there is scope for improvement. We want to any modeler should be fine-tuning for the variances to make sure that the estimators are better. It's better that we do district-wise simulations, and then every modeling should be able to take care of this. And one of the limitations is also to generalize the median parameter values. Yeah, like, see, when you say average testing rates or median case fatality rate, they don't mean anything when you talk about one particular district or state. And that's why you need to have a probability distribution in terms of what the actual values are, and that's where the data is so of paramount value. So the more better the quality of these data elements are, we get a better probability distribution, which we can further use it for. Finally, refine the testing rates using state and district level data. Currently, this data is not readily available. So therefore, what we should be able to do is use these models to predict something like this. Currently, what's the COVID burden? And then if based on my model, if I'm expecting higher disease burden, should I continue the lockdown or not? If there is reduction, then what should I do in terms of my preparedness from a 1 year's point of view? Because as you're all aware, the disease is going to stay, and it's only our response which has to be tailor-made for over a year. Then how can I use my modeling to make these kind of inputs where I can predict whether the case burden is increasing or decreasing? And based on that, how can I prepare in terms of surveillance, my clinical settings, and also for the quarantine? So these are the things in which one has to use the models for. So I would want to end the presentation with this quote, which says, the long-term modeling, the entire trajectory is like falling leaf, and the short term is like modeling a falling bowling ball. So you want to protect yourself against the bowling ball, but then in the moment you want to model for a year or a later, how can you predict how a leaf will fall? So in that analogy, we need to see how we can explain any of the understanding about the disease that we have. And with that, I would like to thank the organizers and all the audience for patient listening, and also, despite the interruption, staying on with this session. Thank you.
So, Dr. Dangareddy garu, yeah. Your microphone looks off. Just
Professor Giri, once again, thank you very much. Wonderful presentation. You have really taken out the fear which usually exists in all of us about the numbers and also all those symbols. I think it was a fantastic presentation, helping us understanding modeling at large, starting from the concept of bias to SIR, SEIR model, and how in real life those models have been implemented, and which are the various organizations globally who are actually working with various models, how successful or unsuccessful they were, implementing or getting those models into the real life. I think it was a wonderful lecture, very useful, and definitely giving the understanding of R0. Probably you have helped us actually to understand how the policy makers look at this R0 and actually do the predictions. In the current scenario of COVID-19, the predictions about the lockdown period, which is required to flatten the curve. You talked about the policy level questions. that gives actually some kind of insight into what happens in the war room or the background when we hear about the lockdown is extended or lockdown is going to end. And probably one kind of message what I personally take is, for a country like India, we cannot have one model, and adapting any global or universal kind of models are not going to give us real kind of predictions. And the more localized and the more deeper insights being added to these models would help us actually to get a better picture. Thank you, Dr. Giri. I think now
We
there
have a
are
couple of questions.
there are a lot of questions. Let us see, how many of them we can take. Are you ready, Professor Giri, for
Ye-
some of the questions, please? Hello?
Yeah, sure, sure.
Yeah.
Yeah,
So,
yes, I can take few questions.
yeah. Um, so, dear sir,
How are we going to do it? When somebody,
don't you feel? I think you have on your dashboard some of those questions. If you want to take from there, or I can read it for you.
okay, so these are the comment boxes. Thanks, very useful. Thank you.
Yeah, there is a
I
chart.
think I have sorted out the questions. If you let me
Okay.
allow, I can read the questions for you.
Yeah, please go ahead,
Please, please,
Pranav.
please, please.
Okay, so that will be easy. So let me start with the model itself. So Dr. Shima asked, are these mathematical models contextual or demographic factors consideration is done?
Excellent question. So I think most modelers have used some amount of assumptions about the demographics. But as I started explaining towards the end, we want far more detailed understanding of what happens at the level of the district, at the state level. So therefore, a lot more contextual information is being added in the models that are being worked on right now. So answer is yes.
Dr. Prem Singh Nirman, very senior macrobiologist from the eastern part of the country, he asked, looking to the epidemiological data and models, of course, uh, can we predict when corona curve flatten?
As of now, we actually don't know because, as I said, around 80%, if you assume that are still susceptible, how they'll get infected, when, what kind of measures that we take in future. So therefore, it's very difficult. But then most of the models at least agree that maybe by mid-July, there will be at least the first peak that we see in India.
Next question we have from Dr. Manjusha. She asks, once the lockdown is through, how long time is expected for the population to develop herd immunity?
Now, that cannot be explained by any modeling because you would want to know what is this serological surveys have to be done. You want to know the proportion of people having IgM, IgG. Then you would want. So those are the things that we would want to assess to know whether in terms of people have developed immunity or not. And if you're able to do that for a very large population of India, then you can assess in terms of what herd immunity is. So even by whatever definition people want to say, whether it is 50% of the people, 60% or 80%, you would have to do testing for that representative sample through the country. Only then you will be able to say. I don't think any modeler will be able to say that.
Dr. Uma has a question which everybody in the country, right from the common man to the ministers and maybe prime minister also want to know. Lockdown, how much period will be really helpful?
everybody wants to know, but I don't think lockdown is the way to go for longer time. We have bought some time by doing lockdown and then extending it, but this is not the way of moving ahead in tackling the disease. So why was the lockdown necessary? It was necessary because we have to get ready in terms of health system preparedness, to be able to test better, to improve our surveillance system better. But there's only a limit to which you can do. So, for example, in the famous analogy by Dr. Kunal in one of the webinars yesterday, you cannot convert a comatose patient into a world-class bodybuilder in a single day. So there's only a limit to which you can give whatever supplementation you can do. So you cannot transform the system to such a great extent during the lockdown that you will be better than the most developed countries. Even the developed countries have not been able to cater to the needs. So then what do? Improve your surveillance, because that's the only path. There's nothing else. Surveillance and testing, and do reverse isolation. Protect the elderly, protect the people with coexisting diseases. Have a plan for this at every district level, every block level. That's the way to move forward in terms of addressing this. So lockdown has to go, and we have to bring in other measures in order to know when the lockdown can be lifted.
Now the question is from Anupam: are we having community transmission now? Can it be predicted through modeling?
So in epidemiology, we have a dictum for this: the absence of evidence does not mean that there is evidence for absence of infection. Beyond this, I don't think I can explain it any further. But then one of the things can definitely be sure is that there is no definition for community transmission in India. So once the definition is there, then we will be able to tell whether community transmission is present or not.
Dilip want to know a little more about in detail systematic errors. What exactly it mean?
So the entire advanced epidemiology is all about understanding what systematic error is and what its sources are. I would be happy to direct Dilip to some of the videos like that. But then for me, so anybody who has done PhD in epidemiology, we spend nearly more than a year to understand sources of systematic error, confounding, selection bias, and measurement error, and then how do you prevent and how do you minimize. But the joy or the beauty of learning these things is if we are able to follow this in terms of our own lives of decluttering from all the biases that we have, I think will be far more better off. So I can definitely direct them to better resources and detail. And if they're interested, they can also pick up masters in public health course with epidemiology in specialization and even PhDs.
Thank you very much once again, Professor Giri. Wonderful fielding of questions, which are which are actually bothering a lot of us. There are multiple more questions, but I think because of the paucity of time, I think we had to end today's session. Thank you very much on behalf of Indian Institute of Public Health, Infection Control Academy of India, and University of Hyderabad, and also on behalf of our academic sponsor, Sunmed Healthcare. Now, colleagues, those of you who are still on air, please note that the next session would be on May 19th, and it is going to be taken by Dr. Sukanya. She is a consultant for Magnet, Singapore. She had been a practicing infection preventionist for last 15 years in various corporate hospitals, and the topic is going to be infection control and prevention from community to ICU. I think for most of the audience, who are actually infection preventionists, for them it is going to be a boon session. Thank you very much, and look forward to see you all again on May 19th. And thank you, Professor Giri, once again.
Thank you, sir. My pleasure. Thank you.
Thank you, everybody, and thanks all the professionals who are in line. So we will be sending you the recording of this by tomorrow morning in the mail. So you all get the recording, video recording of this presentation, as well as the PDF copy of the slides. All the PDF copies of the slides are already available. I shared last mail in the same folder. All four presentation will be available. And it will be mailed to you the detail about that. Thank you very much. Thanks a lot.